differential diagnosis can be tough, but the real nitty-gritty is planning treatment. This is on, right? Can y'all hear me okay? Okay. So there's lots of things to think about as we begin treatment planning. And let's go through some of the clinical decisions we have to make. First, we think about the relative contribution of praxis problems versus linguistic problems, whether it be phonology or language, and you decide where does this child need the most help, right? And then you're going to design your treatment around that. In terms of speech production, which is what we're here to talk about, you have to decide, is this more praxis related or is it phonologic? If it's phonologic, you're going to choose among a number of linguistic phonologic approaches to treatment. We're not here to talk about those today. If, on the other hand, the child has an apraxia of speech, especially a severe apraxia of speech, you're probably going to choose a motor approach. But then within that motor approach, you have to decide on a specific method. Now, to do that, we said you often go to the evidence base, and the most recent systematic review is that by Liz Murray and colleagues, and it's in your required reading. And we know that there are several methods that have been shown to be efficacious, that at least have data that have been published. There are other treatments that may be efficacious, but they have not yet published treatment efficacy data that meets requirements to be considered efficacious in a systematic review. So the three that were, you read that article, DTTC was shown to be effective, but for the severe kids, REST was shown to be effective for the children a little bit older, more moderate impairment, and who need a lot of work with naturalness, rhythm, and prosody. And then there's a linguistic phonologic motor speech approach that has been used for kids that have language problems, phonologic problems, as well as CAS. That's all in your article. So you decide for your child which method might be best. You then have to decide on the frequency of treatment and the length of session. We've already talked a lot about the fact that for kids, especially with more severe CAS, they can't do the kind of work they need to do for more than a half hour. So we usually keep it to half-hour sessions and as often as possible, frequent short sessions. But then you have to make choices about initial stimuli, and when we talk about that, we're gonna do this in more detail in a few minutes and then practice with children. You have to think about how many stimuli. It makes a difference. And there are guidelines within the principles of motor learning that help us make that decision. We're going to veer either toward more mass practice or more distributed practice in terms of how many stimuli. But then you have to decide what phonetic content of the target will be, and you will get that from your motor speech exam. What vowels are distorted? You certainly want to start by building your stimuli around vowels so you can get those accurate, because vowels carry most of the intelligibility. We don't really pay attention to that because our training is all on consonants and our materials are all focused toward consonants, but that will change over time, I hope, because vowels are very important. And then you have to decide on the syllable shape and the length and all of that. But all of that will come from your dynamic assessment. Then you have to decide, well, how am I going to organize this practice? We've mentioned this several times, and this goes back, the principle of motor learning that will help you make this decision are the blocked versus random. And we talked about what that meant, and that recent research from the motor learning folks have shown that if you're working with children or with very complex movement, sometimes you have to go to more mass practice at first to get accuracy and then move toward more random practice so that you can ensure learning. Then we have to decide and think about feedback. We're all good at feedback because we learn that as clinicians. As speech pathologists, we learn to provide feedback. But in the motor learning literature, we have to decide, are we going to err more on the side of knowledge of performance, giving them very specific feedback? Oh, close your mouth a little bit. Oh, not so tight, not so big. Or are we just going to give them knowledge of results? Good. Or, oh, not quite. Can you fix it? And how we're going to start with more specific knowledge of performance early on, or when they're still having trouble being accurate with a word, and then fade that to knowledge of results, and then fade the frequency of even knowledge of results.